Namaskar and good evening, everyone. I welcome you all for today's webinar on immunotherapy in solid tumors. And with immense pleasure, I would like to invite Dr. Srinivas PJ, who is medical oncologist. To you, sir, for the welcome and introductory note and to set the ball rolling.
Thank you. Thank you, one and all. Thank you, all our colleagues, consultants, seniors, and all our students who have joined this, taken time to join this webinar. So, this is about immunotherapy in solid tumors, which we have planned for this evening. So, mainly because so many immunotherapies are coming up, and most of the solid tumors we have are flooded with immunotherapy. Most of the tumors we give first line immunotherapy along with chemotherapy, and because of the availability of newer companies, newer and even affordability is also becoming lesser. I mean, improved the more and more immunotherapy we are using. So that is why we are thinking whether we are planning this seminar. What are the solid tumors, some of the solid tumors role of immunotherapy, and after immunotherapy what next. So that is what under resistant to immunotherapy. So these are the topics we are going to discuss. I think thanks once again, welcome everyone for this webinar, and I request Dr. Vijay to start the first session sponsored by Glenmark on immuno-oncology in motion, tislelizumab promise in NSCLC. Over to Vijay, Dr. Vijay.
Yes, madam, you can present the slides behalf of sir, madam.
Good evening. Can somebody please share the slides from me at the back end? Yes, thank you. You can maximize. Thank you. Thank you so much. So firstly, at the outset, I would like to congratulate Dr. Srinivas Vijay sir for this excellent meeting. Immunotherapy in focus is something which we really want to kind of dig in and delve in and see where we can and what we can explore in the current era. And secondly, when you look at the outside, I'd also like to thank Glenmark for giving me this opportunity to present in this forum. So without further ado, I would like to kind of deep dive into my topic, which is immunotherapies in non-small cell, which is primarily the focus on tislelizumab. Next slide, please. So my session is sponsored by Glenmark, and the scope basically how I'm going to be presenting is primarily a little bit of info on the landscape. Subsequently, what is the drug? How's the mechanism of action? What is unique with this leak? Then we look at some clinical data, and then finally we like to conclude. Next slide, please. So when you look at PD-1, PD-L1 inhibition, there's been a big volcano of eruption which has happened over the last decade or so, with nivolumab being approved in 2014 for melanoma, and then subsequently we've had 11 different PD-1, PD-L1 inhibitors across cancer subtypes. So if you kind of start from the head and neck area to the lung, and then going into the esophagus, stomach, and then HCC and Hodgkin's and nasopharyngeal. So you kind of you've had a wide armamentarium of IOs which have been accepted across the world, starting from Europe, and then you have patients in EU, and then subsequently it's also having approvals in India and China as well. Next slide, please. So if you look at tislelizumab, which is primarily a humanized IgG4 monoclonal antibody, what is more unique with tisli is something to note is the unique binding epitope. So this molecule is clearly different than other PD-1 inhibitors. The binding kinetics is very unique, and it has a distinct binding orientation. So again, these are three terminologies I would like to reiterate. The binding epitope is unique, binding kinetic is unique, and the binding orientation is unique, which is why the molecule is a lot more unique than most of the other PD-1 inhibitors. And when you look at the development plan, it's again global. Initially, most of the studies did happen in China, but then the approvals have been global, and there have been a lot of patients who've been getting benefited by this molecule. Next slide, please. And when you look at the broad clinical development program, you see across cancer subtypes, it's had approval both in the neoadjuvant and then in the adjuvant setting, and then subsequently in the palliative setting as well. There are more than 12 approved indications, and another 5 under review, and it's going to expand with time. Next slide, please. And like I again mentioned, the structural advantage with tislelizumab primarily is, like I mentioned, the orientation and the kinetics. So if you look at the binding of tislelizumab, especially the complete blockade of PD-1, PD-L1 is almost 100%. That is more than 99% is what makes the molecule a lot different. And when you compare this with your pembrolizumab and nivolumab, the partial PD-L1 blocker is only to the tune of 80 to 81%. So which clearly says that there is a superiority in terms of binding orientation and also the binding kinetics. Next slide, please. So I'm not going to deep dive into the mechanism of action. I'm pretty sure everybody knows what PD-1 inhibitors do and why the Fc gamma receptor binding is unique. And it has a, next slide, please. So the unique binding activity of pembrolizumab, or rather tislelizumab with the Fc receptor, is it basically minimizes the binding of Fc gamma receptor on the macrophages. So without Fc gamma binding will allow the T cells to remain activated, and it maintains the effector function. So there is minimal binding, thereby there is maximization of benefit, which is what is the uniqueness with this particular immunotherapeutic molecule. Next slide, please. And when you look at the approvals, again, what is the pharmacodynamic advantages there? The half-life required and the IC50 values required to achieve is almost 1.3 times to 3.5 times higher compared to tislelizumab. And also it has a 30 to 80-fold longer half-life, which is longer than that of pembro and nivolumab. So because of a longer half-life, you would kind of, we know immunotherapies are known to kind of give you the end of the tail benefit and the curve benefit. So with Tisli, again, you would probably tend to see a slightly more advantage on the whole. Next slide, please, because of the longer half-life. And getting deep down into what the clinical evidence is, and which is what we all kind of want to look at before starting these molecules or before considering these molecules in clinical practice. The commonest, next slide, please. So when you look at the rationale, if you look at the major clinical trials across some lung, and then you have studies in esophageal, and then you have your gastroesophageal cancers. So one molecule which has shown benefit across, that is both in the neoadjuvant, adjuvant, and also in small cell as well as non-small cell, is tislelizumab across indications. Next slide, please. So there are a bunch of rationale studies, and they've gone with the rationale study. So again, across subtypes, we have the same. It's just the repetition of the same. Let's deep dive into our primary lung cancer study, which is rationale 307. Next slide, please. So there are also a bunch of clinical trials which are happening with novel combinations. Similarly, across combinations, if you look at it, they've been combining with, say, PARP inhibitors, and you have fruquintinib, and you have your TKIs. So just like how can we counteract resistance? So mechanisms which are known to cause resistance in IOs are using alternative pathways, combining with PARP inhibitors, combining with TKIs, combining with chemoradiation. So this is where we are, and there are a bunch of studies in this particular spectrum. And what is also important to note is they've also expanded to recruit patients across, or rather outside China, which also makes it a lot more say heterogeneous, because that's always been a criticism with tislelizumab studies, because most of the study and the data is coming from China with very limited recruitment because of the geographic bias, which is being clearly addressed when they're taking in more global studies now. Next slide, please. So with non-small cell, the primary study, what I'm going to be talking to you about is going to be rationale 307. Next slide, please. Next slide, please. So rationale 307 is primarily combining tislelizumab with chemotherapy versus chemotherapy alone. This was basically a 3-arm study where patients were randomized to receive tisli with paclitaxel versus tisli plus nab-paclitaxel, or just chemotherapy alone. And this study, next slide, please. And so in patients who responded, continued to receive maintenance for maintenance until disease progression. And this is a study which shows that clearly compared to arm A and C, which is the innovator molecule, which is basically tisli with chemo versus chemo, clearly shows a improvement in terms of overall response rate as well as median PFS. So there's a 2-month improvement in the median PFS with a hazard ratio of 0.45, which shows that a 55% reduction in the risk of death or progression. And when you also look at the median PFS between arm B and C, which is basically the nab-pacli and carbo. So irrespective of whether we use it with pacli-carbo or nab-pacli-carbo, the immunotherapy is definitely resulted in improvement overall, although the numerical improvement with nab-pacli is better. Next slide, please. And you see the same with overall response rate and subgroup analysis. We looked at the subgroup analysis and you see that across subgroups, there seems to be a significant benefit. And what is important to note here is, irrespective of the PD-L1 expression or the stage of the disease, there was improvement with the TISLI and the chemo combination. Next slide, please. And when you look at the overall response rate as well, OS, overall response rates as well as the overall survival, clearly there is improvement in both hazard ratios of close to around 0.49. So very promising. That is something which we have seen in clinics as well. So in the intention to treat analysis as well, you clearly see an improvement of around 6 months on the whole compared to chemotherapy alone. Next slide, please. So this is the data for patients with squamous histology. And when you dwell into the non-squamous histology, you have patients, again, the same slide. Next slide, please. This is the study called Rationale 304, where they've combined with PEM-carbo followed by PEM maintenance. And this is also the same story. Clearly, tislelizumab has shown improvement across subgroups. Next slide, please. So the PFS and OS benefit has been there in both the places. So the PFS, if you look at the progression-free survival, there is a 2-month improvement in progression-free survival with a hazard ratio of 0.63, which says that clearly there is a 37% reduction in the risk of death or progression when you combine tislelizumab with chemotherapy. Next slide, please. When you look at the overall survival as well and the overall response rate, clearly there is an improvement and close to around 6 months, 6 to 7 months improvement in overall survival. And then deeper responses and also your overall response rates have been extremely high, and your CR rates are as high as 3.1%, which is actually promising in a metastatic setting to achieve CR rates. And your disease control rate has also been significant. So response rates were higher, and the duration of responses have always been longer when you combine immuno with chemo, which is what we see with the majority of your immunotherapeutic drugs. Next slide, please. So this is in second line, which was Rationale 303, which combined tislelizumab versus docetaxel as the second and the third line therapy for patients with locally advanced and metastatic NSCLC. And going back, docetaxel has been the gold standard for patients in the second line, and there has been multiple studies which have not been able to push the bar and compete with. But tislelizumab and a lot of other immunotherapeutic drugs were able to do that. Next slide, please. So if you look at it in the second line in patients who have progressed on more than 2 lines in non-small cell lung cancer, this was a study which looked at comparing tislelizumab to the gold standard, which was docetaxel, and tislelizumab came out as the winner. Next slide, please. So it did have a PFS and a OS benefit. And there was a 5-year OS data which was just presented that if you see nearly 20% of patients were still alive on the tislelizumab arm, which is very, very promising. You're looking at 1 in 5 lung cancer patients being alive while on immunotherapy, which is practice changing. And the median OS interval of more than 5 months, numerically with a hazard ratio of 0.67. So there is a significant prolonged overall survival, especially in the PD-L1 positive subgroup where the PD-L1 expressions were more than 25%. Next slide, please. So again, dissecting out, this is basically post-mortem analysis of what the OS data was. If you look at it across the PD-L1, so if you look at it, there has been consistent benefits of immunotherapy over docetaxel. So this is again very promising, irrespective of whether patients did have any other alterations or despite receiving multiple lines and across histology, you seem to have a good benefit with immunotherapy over docetaxel. Next slide, please. And the same goes with PFS and the duration of response rates. So clearly, tislelizumab continues to give you deeper responses, and the overall response rates also been better. And especially in the PD-L1 positive subgroup, there seems to be a greater magnitude of benefit. Next slide, please. And TISLI, like I mentioned, this is one of the most superior PD-L1 inhibitors, which has shown a comprehensive benefit from late to early stage across non-small cell lung cancer and also small cell lung cancers. This is the study where basically looking at non-small cell and rational in the neoadjuvant and adjuvant setting, and as well as in the extensive stage setting. Next slide, please. So across subtypes, we've shown it. So this was one unique study which probably makes tislelizumab a strong competitor across, especially in lung cancers and especially in squamous subtypes. So this was a network meta-analysis where tislelizumab was compared against other anti-PD-1 or PD-L1 inhibitors in the first and subsequent lines in locally advanced or metastatic non-small cell lung cancer. Next slide, please. So in the squamous subgroup, when they compared, especially in the first line metastatic, as per the network meta-analysis, the PFS was a lot superior for Tisli with chemo, statistically compared to any other IO, either you take Nivo monotherapy or Nivo with combinations or Ipi-Nivo. Tisli was definitely way superior, especially in the squamous subgroup, which is making them a strong competitor in the squamous subtype, especially in the metastatic first line. Next slide, please. So when you look at the non-squam, similarly, the PFS benefit has been better. It was ranked the most efficacious across treatment with a hazard ratio of 0.96. Next slide, please. And when you also look at in the second line, Tisli scores over others, and it was ranked the most efficacious treatment across. So network meta-analysis is one of those where you've kind of compared different regimes, although it's a retrospective analysis. It's not a head-on it has its own biases, but clearly this is the only drug which is kind of has this data and kind of explored this. But there are a couple of criticisms with this network meta-analysis. What we have to note, in fact, three most common criticisms which has come for tislelizumab is also one is having the geographic bias, because most of the studies were in China and majority of the patients were of Chinese ethnicity. So would that replicate the global data? That is something to be noted about. The second one is it clearly kind of replicable to all patients? Because there's a lot of variabilities within the country or within across countries. So there's a lot of these parameters, like say smoking habits or a lot of other parameters, genetic factors which are contributing. And thirdly is a very, very short duration of follow-up. So duration of follow-ups have been only between 14 to 16 months. So these are three major criticisms what we would probably look at from the network analysis. Next slide, please. I think with this, I am happy to conclude. Yes, so if you look at the guideline recommendations, these are pretty much a copy paste from NCCN. So it does have CAT1 recommendations across from esophageal to gastric cancer to liver and Hodgkin's and nasopharyngeal. So it's expanding with time. So clearly the molecule is a lot more superior. The biggest advantage being it's cost effective, thereby you're able to get more patients on board to treat because it's a potential game changer, which we clearly agree. Immuno has been a potential game changer. And with Tisli kind of pushing the bar down, you're able to give it to more patients and kind of help more lives. Next slide, please. Yes, with this, I would like to conclude saying that it's a highly active and efficacious PD-1 inhibitor. It has approvals across indications. The concern should also be liver toxicity. There's been some meta-analysis which shows that the liver toxicity is slightly more higher with tislelizumab. However, over the last 6 months, we've been using this extensively. We've never kind of had any liver toxicity. So with this, I would like to conclude and happy to take any questions. Thank you for the opportunity.
Yeah, thanks, Dr. Vijay. Suppose you get any patients where this drug is not indicated. Apart from non-indicated scenarios are there. So whether you want to replace with other immunotherapy or you want to stick to whatever the indicated Vijay.
Thank you so much for the question, sir. So to be very frank, when the patient's in front of me, we would put the best best on the table. So if patients are not affordable, definitely this is something which I would consider. And we've been doing that because even today, for an example, I've had an HCC who ideally papillary metastatic, RCC papillary metastatic who needed Nivo Chemo, but not affordable. I looked I dwelled into some data and there is some data for Tisli with Cabo, which is on the phase 2. So you're more happy doing it because something is better than nothing. I mean, that's how I would look at it. Because if somebody is not able to afford and potentially, these are on par molecules. And fortunately, I've had a little bit more experience in using these molecules in other places as well. So where previously where I worked in Brunei, I had access to these molecules. So I know it's pretty much on par. We've seen patients having responses with Pembro. We've seen patients with Nivo, seen patients with Tori as well as Tisli. So you're more comfortable doing that, I would say.
Okay. And while counseling, I mean, I usually face, I will tell about the US-based immunotherapies and Chinese-based immunotherapies. And apart from this, the other Chinese drugs are also there. So you use that term because some of the patients, I mean, most of the people with the Chinese products are there, they usually refuse. Anything you have come across, or you don't use that Chinese word actually?
I mean, it's an excellent question. I actually use it, sir. I'm more comfortable doing that because we do put that out for the patient to decide. Because now that molecule is going to be more and more cheaper and cheaper, I think there are newer molecules which is like say 40, 45 PA. So you put that on the paper and let the patient decide because you tell them clearly that your experience has been better with the older molecules. Having said that, the newer molecules absolutely have nothing which is lacking. So that's clearly something which you tell your patients. And it's also the trust what we kind of, I mean, the confidence with which we speak, I believe that also kind of equally matters for the patients to get convinced.
Yeah. So I think I mean that second and third line docetaxel versus tislelizumab, I think very good. Yeah. Have you experienced any using in second and third line only immunotherapy?
Yes, sir. Yes, sir. We've used it. So in the second and third line, we've been using it, especially if we've not given IO in the first line. We've
Okay.
used IO as a monotherapy irrespective of the PD-L1 because nivolumab had the strongest data, but then we've been using. I've used one patient with TISLI in the second line post progression. So we've been using that.
Okay. Okay. Thanks, thanks, Dr. Vijay,
Thank you,
from
sir. Thank you so much for the
Denmark
opportunity.
for sponsoring that session. So I
Thank
would
you.
like to invite Dr. Satish for next topic on the clinical from clinical trial to real world Tecentriq bevacizumab in HCC, a real world cohort study by Dr. Satish from HCG Bangalore. Sir, over to you, sir. Sir, you're mute.
Hello, Srinivas.
Yeah,
I'm audible, no?
yeah, you're audible now. Yeah,
Just like I'm sharing my slide. Just 1 minute.
yeah. So this session is shared by, I mean, sponsored by the Roche. Thanks, Roche, for this sponsoring. Over to you, sir.
Yeah, the slide deck it is shared by the. Hello, can I share? Like they're sharing actually the slide.
You can share the,
Srinivas,
sorry, you can share, I think.
but I think that I cannot share this while participant is sharing. Means I think they're already sharing. I think they'll.
Um,
Yeah, that.
they're
Okay.
sharing? Yeah.
They can put in a presentation mode. Yeah. Good everyone. Thanks, Dr. For giving opportunity to talk. And we have a lot of clinical trial, but even the real world data is very very important because what we say clinical trial is very patient only will they'll take it eligible patient, but clinical the trial other than that one real world the data is very challenging. Let us see this what is the data about the transcentric and the atezolizumab with bevacizumab in the unresectable advanced hepatocellular carcinoma. This is from real world data. Next slide please. Can you move the slide? Yes, next slide, please. Yeah. So like we have that phase 3, the global randomized study that is a Embryo 150 is the final trial in the hepatocellular carcinoma. This is the first trial. It is to say that landmark trial in the in hepatocellular carcinoma to change that immuno-oncology is going to change the game change hepatocellular carcinoma. After that, we have other trial that is known as the Himalaya study, and even we have the that nivolumab data is there. Like let us see this. What is the data like? Because trial setting and outside the clinical trial. Let's see that. Next slide, please. I was thinking that I'll share that. Okay, here like see that we have a three trials. Like I was telling about this study like that. Beginning it has come as the present the atezolizumab and bevacizumab, that Embrace 150, and later Himalayas the published, and later we have the ASCO publication 2024. We have a now like latest FDA approval also is there. This is the first only global assigned treatment in the advanced hepatocellular carcinoma to show that improvement in the response rate, progression-free survival rate, and median the overall survival rate. And we have again overall OS data with this at Embrace study 19.2 months when compared to standard of farm 13.4 months. And if you come to the Himalaya study, you can see that that is definitely is improvement with the compared study, the double IO study, first double IO study. And next now we have the development data is there up to 23.7 months. We know that the median PFS, you can see improvement in the that atezolizumab, bevacizumab, and we are seeing in the that new ipilimumab data. But response rate, you can see that definitely improvement in the that Tecentriq and bevacizumab versus the new ipilimumab, but we don't have any the response rate in the Himalaya study. And duration response, definitely you can see 74% of people are responding. Median follow-up also, like we have this because we don't have the long-term data of this. We still now whenever hearing this, where is the long-term data? Do you have that? Only the median follow-up is data is very short, and we don't have a long-term data. That was the question is to be arise for multiple discussions. And we have this data like Himalayan study. We have that one. The data is almost like nearing 35 months of follow-up is there. Let's see that like this study is the real world data is it's give the boosting our confidence. Okay, they have a like a 4 year almost like a 4 year study of the 42 months of the follow-up study of this the Tecentriq and atezolizumab is there. Next slide, please. Next slide. Okay, sorry, previous slide, please. That's what I was thinking that I'll share myself. Yeah, we can see that like the Embrace 150, you can see that is a pioneer like first line meta like, advanced hepatocellular carcinoma is own the first line immunotherapy is made a game changer in the management of hepatocellular carcinoma. But only thing is that we don't have a long term data less than 3 years only is there. That's why the confusion. Okay, we have initially for the good response curves are like separating separating from beginning. Then later we don't have a long-term data because we have Himalaya data 5 year studies there, and we have other study also we have a long-term data follow there. We don't have this was one of the long-term data with this regimen was a questionable that was with previously. Next slide, please. That we have that supporting evidence from the real world data gives that boosting us. Okay, we have a long-term we can see. Next slide, please. Next, you can go to the next slide. See that what you see in the clinical trial data and we are real world data, you can see that like it is definitely complement our what the real world data. You can see here like real world data, what is RCT, randomized control study, there definitely that trusted mechanism and of evidence generation is there. We have a clear hypothesis there, and with in high internal validity is there. We have a homogeneous type of should be there, fixed like inflexible environmental situation because you don't have that real data. You try to have the out of the that eligibility criteria will be treated, but they are the basic for the standard basic guidelines, and clinical decisions will be there. But real world evidence, you can see that is representative of routine or clinical treatment and supports our wide variety of clinical decision where that we don't have a large clinical data is not available, a long-term data is not there. This the data supports us and supports the definitely regulatory approval, and their complexity is there because of the limit potent limitations what compounding and biases was like that one thing complexity will be this needs like extrapolation of this one, and adoption is not perceived like that. Definitely it gives that complementary to our randomized the control studies. Next slide, please. they are definitely important for our decision making routine, and you give the more the support evidence. The real world data also is helping. You can see that there is a definitely the strong real world evidence for the first line management of atezolizumab and bevacizumab in advanced HCC. You have almost like you can see 123 real world studies publications are there for this. 7 meta analyses are available. More than like 100 like a case study series are available. That gives that as more robust data. Not only this only one study we are telling, okay, this like is we have a data, but like we have a longest follow-up of data also is there with this. I'm going to present in the next coming slide. Next slide, please. You can see here like we have that detail what you have a data for the that real world evidence. You can see here that phase 3, the first topmost one is the phase 3 data of that atezolizumab and bevacizumab. You have the 19.2 months of follow-up actually, you can see here. And later we have our real world evidence actually with other AB real studies there. And we have study from that D. Castro's natal study is there, and Remini natal study is there, and we have Ramasamy et al. From the Indian that real data also is there. You can see here like that we have like AB real studies almost like 296 patients are there. This is from the 14th center from Asia. You have that you can see there median OS is 15.7 months versus the 6.9 months. Overall response rate also almost 30%. It's a really substantial evidence that it's almost mimicking like the Embryo study. And also even previous other studies also you can see that definitely is there meaningful improvement in the OS study, OS of this patient, and also response rate is almost 25 to 30%. You can see that like other even what we see in the Ramasamy et al. Also you can see that definitely is the improvement in the OS, and also response rate also is better, and treatment related side effect also. Next, please can you go for the next slide. See, we have a data known as this is the long. This means like we have a clear we have the real world evidence of a long term hepatocellular carcinoma data from the this atezolizumab extended follow up of almost 42 months from the atezolizumab bevacizumab in the advanced hepatocellular carcinoma from the chief prospective study. This is the prospective real world data. Next step, please. See this like the it is a very prospective real world data ever collections. You can see here like it's the embryo. It is definitely is a landmark phase 3 data. The first, yeah, and like the aim of this study is to see what are the OS data and EFS data, best overall response from this regimen, large prospective multicentric data collection from the French population. It is a like and also to identify what is the predictive factor for the mortality and progression. You can see here this is a French population what has been taken here, and as a multi-center prospective study, almost 33 French centers are involved here from the 2020 to 2005. All the patients treated with atezolizumab bevacizumab, the first line treatment were included here. Childhood C and BCLC, the D are excluded here. OS and PFS were assessed as per the Kaplan-Meier curve. Actually, objective response as defined as the presence of either complete or partial response, and overall baseline characters during the study were all analyzed, and as per the statistical analysis was mentioned here. Next slide, please. Next slide. I think there is a lag. Actually, yeah. You can see here like go back to the previous slide. Okay, you can see here that this is a flow of a study. You can see that almost like nearing almost 4,500 patients, like they're like what was they taken here, like almost in this first line data, almost 894 patients. And here there are a couple of patients are excluded, almost like 14 patients you can see because of the child cook C and BCLC stage D. almost 880 patients are included here. This is a baseline characteristic of the underlying ETL. This ETL is also coming a factor. Not only non-viral ETL is also is going to see almost 16% here, and childhood A and liver functions. So you can see esophageal varices, how many patients are large varices also. Definitely this data is very supporting actually for the day-to-day practice. And also that the vascular invasion and metastasis, all the things are almost one third of the patients are metastasis from the beginning. Next step, please. You can see here complete like the median OS was almost 22.8 months, and you can see here like that 42 months you can see 44% are still alive. That is at the end of the 42 months. This is very impressive. And also you can see multivariate analysis is those that have esophageal varices and ascites and ALBI score is the grade 2. They like they try to have the like hazard ratio is like try to have a opposite direction. Next step, please. Next step, please. Yeah, you can see overall survival rate as per the childhood criteria. You can see childhood that definitely is supporting us the real world data also of other studies and also even global studies also. Childhood care definitely they do well. They have a median OS of 27.4 months versus the 9.8 months in the childhood P. You can see here they are statistically significant, and also as per the BCLC staging, BCL staging, in B, you can see that they try to do better. That is OS of 27.8 months versus the 18.5 months in the BCLC and BCLC stage in the C category. You can see that definitely gives the boosting actually that we have longest data with a different this data we didn't add that long-term data is giving a boosting us. Next slide, please. You can see here like even ALBI score also is one of the important because we use most of the time childhood criteria. Even this is also very important actually. That is based on the like albumin and the bilirubin, all the things to be taken in the criteria. It's a grade 1 is there and a grade 2, grade 3. The grade 2, the grade 3 they don't do well. The OS is not reached. The ALBI score 1 is there, definitely they'll do very well. The median survival is not reached. If it still at the end of 42 months, still they do very well. You can see this is one of the prognostic factor. You can see that can take it. And ALBI score of like a 2 and 3 grade, actually you can see that 15.5 months for the score actually. And you can see vascular invasion also one of the negative prognostic factor. If they have vascular invasion, they don't do well. If the presence of this one, that median OS falls down, you can see the 16.2. Next slide, please. Next slide, please. You can see the progression phase are not to OS. You can see PFS also median PFS is for 5.8 months. And as per the even child took other like multivariate analysis he has done actually to see the progression phase that is anything factors affecting. NLR ratio is more than 2.9. That is also one of the negative factor. This definitely holds good for many of the immuno-oncology studies. And BCLC staging 3 C is like a negative factor, and alpha protein elevation also is negative. Like it is neutral actually, not a staging factor. But book B and BCLC staging that C they're right to have negative factor. Next slide, please. Next slide. You can see here like this your PFS like a child book like the previously OS defined as per child book criteria we see here. Also you can see the PFS data also like it's child book A is better compared to child book B, and also PFS data also is like try to better for the child book of the BCLC staging of B versus the C. That the worsen that prognostic of the Warfan status. B score is detrimental if child book is B, like C, like they're like they're all try to have a detrimental effect. Next slide, please. They're all supported for the prospective what are the random studies. You can see here like the best response what you had that like the overall response is 20%, whole the including stable disease almost 50%, progressive disease is seen the 22%. These are the difference between the best is as per this BCLC staging, all the things is the factor age, like a child book criteria, B score, like response wise. But PFS and OS definitely matters. You can see here OS as per the best response. Those who have a best response, like they try to do long term very well. That is one of the factor. Even the response they achieved better, they try to have long term good OS. Next step, please. You can see this friends real world data definitely confirms that the benefit of this atezolizumab and bevacizumab in combination therapy for the long term based on the three key factors. You can see 44% of the patient, their overall survival, they try to survive beyond the 42 months, that is 3.5 years. And 23 months of median overall survival, that is the best one. What is like you can see that this, what we have this Himalaya study that like we have the nivolumab, ipilimumab study also median OS data. You also seeing that almost it is the largest number of patients. You can see here almost 800 patients were analyzed here, large number of patient and multicentric data. We have almost like 42 months of almost like 40 and 42% of 44% of people they're still alive. It's give the very robust confidence for that we have a long term data with this regimen. Next slide, please. Conclusion from this, like see the overall rate at 40, unprecedented in the real world practices. You can see that reinforces our long term durable benefit of this combination of atezolizumab bevacizumab in advanced hepatocellular carcinoma. It gives that like we had only that whole short term, like only that follow up was very limited in the that embryo 150 study. This study definitely gives a very post boosting for the long term data surrounding that gives that because with a large number and having almost 23 months of OS median basis gives that definitely that thanks to the Roche to giving this data and to bring it to everyone knowledge actually is easy for accounting because many times we do that we have that Himalaya data is there, 5 years data is there, and we have the other studies coming. We don't have any that the data to putting all the thing. This thanks to the Roche to bring this the data to bring to the HCB and healthcare professional to understand and easy for the treatment. Thanks. I'll stop here, and any questions are happy to take.
Thanks, Dr. Satish.
Srinivas.
I think, yeah. I think most probably real world evidence is more practical data or the more, I mean, reality check for the particular drug. I think definitely we have very large experience with atezolizumab and bevacizumab combination. So now recently we have two IO combination that is durvalumab and tremelimumab and Evo and EP. So I mean always the question comes how to differentiate or how to choose which regimen one over the other. So any take on that, sir, Dr. Satish?
See, that is a good question. Like that, we used to have a subgroup analysis. Like when you have this data, yeah, the vascular invasion, very high risk factor. Yeah, we want a rapid response. We used to have this. Okay, that atezolizumab, bevacizumab is there. We want to have this. IO combinations don't have the rapid response. In the symptomatic disease, we try to prefer unless it's a contraindication for the bevacizumab. That was one thing. All the patient we try to prefer, but we to prefer that the IOO combinations, especially in the case of non-viral etiology. That's what one thing subgroup we don't have. That is was not designed to have a etiology, but when subgroup analysis was there, we didn't add that robust evidence. We have a lot of real evidence with this even atezolizumab versus map. It works even non-viral etiology also. That gives a more confidence actually. And now low like that low burden disease, limited disease, we can try to use that IOO combinations, and we want to have rapid response because because I was a part of Himalaya PA that publications also, because we have that vascular invasion of there are excluded criteria. So up to V2 was included, V3 and other things they are excluded. Because one the atezolizumab is the one study we have that the grading of higher the grading of vascular invasions are included in this study. That's what is gives a lot of robust evidence. They try to have a worst type of disease. We have still they have the good response. They have the maintaining response, and we have even long term data also is there that gives a good confidence. I my this thing is that the IOA also is important. We try to see that I'm not telling you that they are not important, but only thing is that the asymptomatic low burden disease that and non-viral try to do that. That was a practice. Now we have a data for non-viral also with this atezolizumab and bevacizumab. They are even though not well stratified to do this, understand this one. try to convince about the thing. But only thing is that the cost is the factors coming in, in our day-to-day treatment. Because the duration of treatment, how is feasible, like, that's what we have to see. That if you calculate about IOIO and long-term data with that, how economically works, that's what is a practical challenge for all consultant. And even bevacizumab and continuing atezolizumab, what is the practical that we have to see. That like if you have a 2 years data, at least 3 years data for this, what is the calculation of financial thing, that is the one of the thing we have to see. I think I'm convinced with both the regimens, IO also IO bevacizumab, but only thing is that I want rapid response. Other things I try to fill for this. Thank you.
Yeah, I think yes. Usually, rapid response with bevacizumab we have seen HCC, and given the side effect profile of double immunotherapy, especially the CTLA4 inhibitor in both of the studies, we have. I mean, we're a little bit hesitant to use in some of the patients. I mean, because we have large experience of this combination, so we are very much comfortable in using this drug. Though the bleeding tendency is the one which always makes us cautious. So one question in chat box by Dr. Sumit: should we consider having positive status BP4 blocks to consider therapy according to etiology? I think he has already told. I think VP4 blocks. I mean, VP4 category was included in the in IMBRAVE 150 study, which were not included in any other studies. So this is the very poor prognostic category where it indicates the advanced disease, and the patients on this category also has done well with this atezolizumab and bevacizumab combination. Yeah. So Dr. Satish, you want to comment on that?
Yes, definitely. That Himalaya, that is their exclusion criteria, and even other the newer IO study also is exclusion criteria B4. The only that study is included BP4 is this one. Okay, like the adlizumab, bevacizumab we can include, but only thing we have to very carefully watch for the liver function with the help of hepatologist. I think we try to see that, because sometimes like all the patient may not do well in this category, but among the choice, if you have this is the one the choice they have a have a strongest evidence and the clinical data is there. To VP4 we try to use the atezolizumab bevacizumab. We have to closely monitor them. That sometimes we have a sudden deterioration. Even if you don't do also they deteriorate, and with the therapy we have to be closely monitor. That's one suggestion from my side.
Yeah. Thanks, Dr. Satish, and thanks, thanks, Roche, for sponsoring this session. So, moving on to the next session, so we will be Dr. Aditya, who is becoming a new consultant in our medical oncology, just passed out from HCG Bangalore. So, he will be talking on treatment strategies after immunotherapy progression. So, he is very fresh from his theory. I think we will hear from him the post progression immunotherapy, what are the things, because so many immunotherapies are available, affordability is also there. So what are the things we are going to do? So we will hear from Dr. Aditya. Over to Aditya, doctor.
Yes, sir. Good evening, sir. Treatment strategies for post progression on immunotherapy. Usually, the progression on immunotherapy happens when there is either resistance to the develops to immunotherapy. So there are two types of main resistance which occur, like primary resistance and secondary resistance. Primary resistance definition is if the disease after starting immunotherapy, if the disease is stable disease for less than 6 months, or a progressive disease during treatment, or within 12 weeks of the last dose, then it is defined as primary resistance. Secondary resistance is if there is partial response or stable disease for at least more than 6 months following treatment with immunotherapy. Then after that it progresses, then we can tell it as secondary resistance. So the main mechanisms for immunotherapy resistance are if during primary resistance. Uh, one Primary resistance is if tumor cells that have developed resistance, if there is chronic stimulation, they develop resistance to interferon gamma signaling due to JAK1 and JAK2 mutations. This induces PDL1 upregulation and inhibits T cell reactivity through PD1, PDL1 independent pathways. So this is one mechanism where there is a primary resistance. Another mechanism is there is main thing is JAK1, JAK2 mutations, and as well as there are independent PD1, PDL1 independent pathways. So we will see what the PD1, PDL1 independent pathways are in the next slide. So secondary immune resistance, this is mainly because of four mechanisms. It is mainly due to chronic inflammation. There is interferon driven immune response and resistance mechanism. Chronic interferon gamma exposure leads to selective pressure on tumor cells, leading to mutations and immune evasion. There is immuno editing as well as selection pressure in the tumor cells. If there is response to immunotherapy for a long time, and there is alternative immune checkpoint activation and acquired resistance mechanisms such as TIM3 activation, and impaired CD8 T cell memory and acquired resistance are also seen. These are the main mechanisms for secondary immune resistance. So, as a whole, it is mainly divided into three parts: dysregulation of immune response, and which is due to chronic inflammatory signaling, leading to expression of alternative immune checkpoints. And the tumor microenvironment also has macrophages, neutrophils, and regulatory B cells, which secrete certain factors like TGF beta. This results in fibrotic microenvironment and anti-inflammatory microenvironment, so that the less number of T cells get activated, and this further results in decreased response to immunotherapy. And other mechanism is myeloid cell mediated resistance to therapy, mainly the macrophages CD206 plus, which is the tumor associated macrophages, dendritic cells, and immune suppressive monocytes. These play a key role in promoting resistance to immunotherapy. So main molecules involved are insulin-like growth factor, TGF beta, platelet-derived growth factor, and VEGF. So these molecules, they are secreted into the tumor microenvironment yeah, by the cells which are present in the microenvironment, like myeloid cell derived cells. So these secrete these factors, and which result in immune resistance. And the tumor associated macrophages also express PDL1, PDL2, CD80, CD86, and TIGIT ligand, which help in immune evasion. So these are the main molecules which are involved in resistance. So what strategies we can use to mitigate this myeloid derived cell mediated immune suppression is, we can use inhibitors of CSF1R, which is a macrophage growth factor receptor, and we can use inhibitors of myeloid cell trafficking receptors like CCR2 and CXCR2. We can also target receptors like MERTK and AXL, as well as other lipid processing regulators like TREM2. We can also target specific PI3K inhibitors can be used along with immunotherapy to inhibit this myeloid specific kinases. So the myeloid cell lineage cells do not cause immune resistance. These are the main targets which are under study for to prevent immune resistance. So these are the co-inhibitory immune checkpoints. As we can see, PD1 and PDL1, CTLA4 and CD80 and 86. This PD1 and CTLA4 are present on T cells, whereas PDL1, that is ligand, and CD80 and 86 are present on antigen presenting cells or tumor cells. So when these molecules are bind to each other, there is decreased immune response, and by decreasing inhibiting the activation of T cells. So these are so what mechanism we use for immunotherapy is we use PD1 inhibitors or PDL1 inhibitors or CTLA4 inhibitors, so that this interaction gets inhibited, and when this happens, more number of T cells are activated. This results in immune activation and tumor cell killing by the activated T cells. So this was the mechanism which was used till now. But what happens is other non-PD1 and non-CTLA4 pathways are there, like TIM3, LAG3, and TCR and TIGIT molecules. So these are the other co-inhibitory immune checkpoints which can be activated further even after giving our immunotherapy, which cause immune resistance. So these molecules can again be targeted, and these molecules are under study, like TIM3, LAG3, TCR, and TIGIT, which are under study now to prevent immune resistance. Already we are using we're using many molecules in this, which will be explained in the next slide. So these strategies to overcome immune resistance are by enhancing T cell infiltration. This can be used by adding antibody-guided light fusion protein along with immunotherapy. Overcoming T cell exhaustion. Chronic T cell stimulation results in T cell exhaustion. So to prevent that, we use nivolumab, that is a PD-1 inhibitor, and we use other co-stimulatory molecule inhibitors like anti-TIM3 blocking antibodies and anti-TIGIT antibodies. So that we use the other pathways to prevent immune resistance. And inhibition of epigenetic modifiers like histone deacetylase inhibitors, which cause epigenetic means the post protein synthesis, these proteins are altered, these molecules are altered so that immune resistance occurs. So we prevent this epigenetic regulation, so that histone deacetylase inhibitors, if given along with immunotherapy, it will prevent resistance, development of resistance. So these are other strategies which are under study. And improving the tumor microenvironment. So tumor microenvironment, all these VEGF, TGF, and PA3K molecule, PGF, VEGF, they are secreted into the microenvironment. So when we add VEGF inhibitors like bevacizumab along with immunotherapy, this will inhibit the VEGF in the microenvironment, so that the resistance also resistance is prevented. And along with that, we use T cell priming enhancement by adding chemotherapy, radiotherapy, or adding cancer vaccines. Like cancer vaccines with ipilimumab, TVEC vaccine is added. This is herpes HSV. Using the HSV, we target melanoma cells. In melanoma, we use this vaccine to in if there is progression post immunotherapy in third line. This is the vaccine which is already in use. TVEC is the vaccine along with immunotherapy, ipilimumab or pembrolizumab we can add. And along with that, radiotherapy is also added. Radiotherapy, when given to the cells, it results in cell death and release of neoantigens. When neoantigens are released, it will cause further T cell priming and increase the immune response. So with immunotherapy, radiation can also be used for T cell priming. Other combination with other pathways which we can use for for tumor cell killing are MAPK pathway can be used, and BRAF ERK inhibitors can also be used along with immunotherapy, provided these are under studies. And so that immunotherapy with lenvatinib is already in use in second line or third line of endometrial cancer, so that these pathways are also used, which further cause tumor cell killing and prevent the downstream pathways. So these are other combination strategies which are under use. So these are the drugs which are mainly used, already CTLA4 nivolumab when combined with ipilimumab, there is further increase in activity because it increases the T cell activity. So with PD-1 inhibitors, CTLA4 inhibitors can also be added to enhance the immune response. Other molecules which are activated are LAG3, that is relatlimab. Nivolumab along with relatlimab is also used. This is used in recently it has been approved in melanoma also for treatment. And other molecules like TIGIT inhibitors and CAR-T is also being used. CAR-T is another form of this one, where T cells are activated by inducing response against a certain target. So CAR-T has also been used, and JAK1/2 inhibitors and CSF1R inhibitors. These have been added along with immunotherapy to prevent resistance. So a few of these inhibitors are still under study. Their phase two studies are still going on. Only one which is approved till now is relatlimab, which is a LAG3 inhibitor, which is combined with PD-1 inhibitor. So this is the only one which has been accepted till now. And as shown from before, ipilimumab and nivolumab, that is CTLA4 inhibitors are already in practice. Along with PD-1 inhibitors, they're already being used. So a few phase two studies are going on where JAK inhibitors are used along with immunotherapy. Ruxolitinib or itacitinib have been added to pembrolizumab in non-small cell lung cancer, where after 2 cycles of pembrolizumab, it is shown that there is no response and progression post immunotherapy, that is pembrolizumab. When there is progression, these JAK inhibitors have been added have been added. So post that, it has shown that there is better response. Overall response rate has increased adding JAK inhibitors. And it has also been few studies or phase 2 studies are still also there where JAK inhibitors are added to nivolumab in Hodgkin's lymphoma, which has showed response in patients who initially failed to respond to immune checkpoint inhibitors. So this is the same thing where lag inhibitors have been used, which the alternate pathway are inhibited so that immune response is increased. So this is the same thing. JAK inhibitors. These are the main molecules which are targeted. JAK, LAG3, TIGIT, TGF, beta, VEGF in the tumor microenvironment. So these are inhibited so that the immune response will increase. So these are the other pathways which can be targeted. So this is the timeline of drugs approved to prevent immune resistance. Post immunotherapy with pembrolizumab and nivolumab, anti-CTLA4 inhibitors along with anti-PD-1 combo has been approved in 2015. After which CAR-T was started in 2016, and now anti-LAG3 and anti-PD-1 combinations have been approved for melanoma, and now trials are going on. And now pexidartinib CSF1R inhibitor has been approved. It was already in use for tenosynovial giant cell arteritis. Pexidartinib was being used till now, CSF1R inhibitor. With immunotherapy, there are no new studies that CSF1R inhibitor along with immunotherapy would increase the response, immune response. Now, further studies are going on. Phase 2 studies like JAK1, JAK2 inhibitors and PA3K inhibitors are under study. So this is the use of immunotherapy along with other molecules which target the other pathways. Now, if what question is, if post immunotherapy response, is there a role of using immunotherapy again by rechallenging it, or changing that immunotherapy, or if or escalating the immunotherapy by addition of a new by new class drug? So is there a new is there a role based on the paper recently released? Only melanoma is the only one where it has shown that there is a response with immune rechallenge or immune checkpoint inhibitor escalation. So these are the terminologies. Retreatment is if once the immune checkpoint inhibitors are given and it is discontinued because of any toxicity, and subsequent if the same class is used, it is called retreatment. Rechallenge is in between another chemotherapy was given and again the new immunotherapy has been started. That is rechallenge. So ICI escalation means along with immunotherapy, new immunotherapy has been added. Like nivolumab was given initially. Now nivolumab and ipilimumab has also been added to nivolumab. That is called ICI escalation, where a new drug has been will be added if there is progression. So these are the terminologies what I've explained. And current data regarding retreatment or rechallenge or ICI switch in melanoma, although head-to-head trials are unavailable, retreatment and immune checkpoint inhibitor escalation could be considered for patients with resected stage 2 to 4 melanoma who experienced progression disease after discontinuing initial ICI treatment. So this is the only where retreatment or rechallenge has been beneficial. And ICI escalation, if if monotherapy was only given in the initial treatment of stage 4 melanoma unresectable, stage 4 unresectable melanoma, adding another dual immunotherapy showed benefit. So this is what it showed, but we should closely monitor for adverse events. So these are the main studies which I see which showed benefit. Only thing is more than rechallenge and retreatment, escalation with immune checkpoint inhibitor showed that adding dual immunotherapy showed a better response than single immunotherapy. But the benefit was less with rechallenge or retreatment. The benefit was less. If there was progression and there was a rechallenge or retreatment, the benefit was less. So these main studies are there where retrospective and prospective studies have shown benefit in melanoma. In RCC, the standard of care is in immunotherapy with TKI, if it is a stage 4 RCC. The main thing is only if monotherapy was given, due to any toxicity, ICI escalation strategy was the only one which showed benefit, whereas monotherapy and rechallenge or retreatment did not show any benefit. There are no trials also to show that any benefit is there in rechallenging immunotherapy in RCC. Similarly, in non-small cell lung cancer also, there is no head-to-head trials which show that rechallenge or retreatment shows any benefit. Then in urothelial carcinoma, Data from studies indicate that selected patients with urothelial carcinoma who do not respond to nivolumab in the second line setting, means initially only chemotherapy was given, and second line nivolumab or pembrolizumab can be given. But instead of nivolumab, if it could be treated with nivolumab plus ipilimumab in patients with PD-L1 expression positive, it showed that there is better response compared to monotherapy with immunotherapy. That is single agent immunotherapy. So here, immune checkpoint inhibitor escalation has showed the benefit in urothelial carcinoma. So most benefit is in melanoma and urothelial carcinoma. So conclusion, in melanoma, ICI escalation appears to be more effective than retreatment or rechallenge with ICI monotherapy in patients with metastatic or unresectable stage 3 or 4 disease. In advanced or metastatic RCC and urothelial carcinoma, ICI escalation appears to be effective in some patients who do not respond to initial monotherapy. By contrast to our knowledge, ICI escalation has not been investigated in non-small cell lung cancer. Thank you.
Yeah, thanks, Dr. Aditya. I think, yeah, so this more and more of this knowledge is required, I think, in coming days, because we are using so many immunotherapy for almost all the cancers. So definitely, yes, the lenvatinib with the pembrolizumab is one category where we are using in TK, I mean in RCC, and yes, LAG3 antibody with nivolumab is one which is coming up. Maybe it is not there in India. I think most probably in another 3 to 4 months it may be available. Yes, definitely. Most of the trials, phase two trials itself, they have failed rechallenging with immunotherapy. Whether there is a if there is a failure of single immunotherapy, rechallenge with other immunotherapy has not done anything, or challenging with the combination also has done some responses, but it has not gone. Not got much of the benefit in most of the patients. So rechallenge is definitely is not the scenario in most of the cases. So we have to look for some of the newer antibodies which are coming up in a few years. So there was one question from Dr. Sumit: can we rechallenge immunotherapy after initial response? So if response is there, so if it is primary resistance or secondary resistance, it may not work. Suppose there is a response for 2 years, 3 years, and we stop it, and then disease comes back, then we can use rechallenge with that. Otherwise, within 1 year the disease comes back after immunotherapy, so the combination immunotherapy may also not work. So that is what this most of the studies have shown. And one more question from Dr. Sumit: grade 3 esophageal cancer, I mean esophageal varices is there, and banding, should we select therapy? How long after banding we should select therapy? Usually as per the trial it is around 2 to 3 months. I think we cannot wait. Prophylactic banding is required. I think we have gone immediately within 2 to 3 days or within 1 week we have started the immunotherapy. Otherwise, if there is a bleeding risk, bleeding and then banding is done, I think then we have to wait for minimum 2 to 3 months before starting the therapy. So there, in that case, I think double immunotherapy comes into picture. So thanks, Dr. Aditya, for enlightening on immunotherapy resistance mechanism. Definitely, this is going to be a more and more topics on this we are going to hear. So, so next, moving on to the next topic, sponsored by BM.
Please.
Also, I'll share.
Yes, please. No, thanks for this opportunity to talk on etopitant and palonicetron combination in the treatment of nausea and vomiting. Next slide. We are going to predominantly talk today about netopitant and palonicetron combination. Now we know that antibody drug conjugate is coming up in a big way in oncology. Now the nausea and vomiting associated with antibody drug conjugate is moderate to high risk emetogenic potential. Now, what is the unmet need of antibody drug conjugate in the chemotherapy-induced nausea and vomiting? This aspect has not been studied in the clinical trials, and it is left to the physician choice for treatment. clinical study of antibody drug conjugate induced nausea vomiting, and how are the guidelines telling us to manage antibody drug conjugate induced nausea and vomiting. Next slide. Now we know antibody drug conjugate prescriptions are growing. There are several drugs available both in solid tumors as well as in hematology, like TDM1 and trastuzumab deruxtecan. Then we have polatuzumab vedotin and brentuximab vedotin in hematological malignancies. Then we also have enfortumab vedotin in bladder tumors. Next slide. Now, risk of nausea vomiting during chemotherapy varies with clinical factors, including the drug type and the host-related variables. Vomiting rather than nausea is used as an indicator for appropriate category. Previously reported risk factors for chemotherapy-induced nausea vomiting included younger age group, female sex, and history of chemotherapy-induced nausea vomiting, motion sickness, morning sickness during pregnancy, non-smoking and anxiety, and high pre-treatment expectation of nausea and vomiting. Now, there's no data to determine whether these are the risk factors for antibody drug conjugate induced nausea and vomiting. So these have been not studied in the clinical trial for nausea and vomiting. Next slide. So there are two classes of antibody drug conjugate. One it is a microtubule inhibitor, other is a DNA topoisomerase inhibitor. A classical example of microtubule inhibitor is TDM1, and which, the classical example for DNA topoisomerase inhibitor is which blocks the donomycin. Next slide. These are the several antibody drug conjugates available. One is brentuximab vedotin, which is a CD30 antibody drug conjugate. Polatuzumab vedotin for relapsed and NHL, DLBCL. Enfortumab vedotin for bladder cancers, which are platinum ineligible because of the poor performance status. And there are several others like tisotumumab vedotin for approved for cervical cancer, and several other drugs which are in the pipeline, BCMA, antibody drug conjugate for multiple myeloma. Next slide. Now, hematogenic risk associated with antibody drug conjugate is not very clearly assessed. The evolving technology of antibody drug conjugate led to a new indication with high levels of efficacy in terms of improving PFS and OS in randomized trial. The targeted therapy with antibody drug conjugate, we know, is still a chemotherapy which goes and binds to the cancer cell, and the chemotherapy is released. The toxicity are mostly to the release of the payload at the off-target sites and the bystander effects. TDXD and santumab govitecan are classified as moderate or high level risk of nausea and vomiting. Now, adverse events should be prevented and closely monitored and treated with adequate supportive care. Understanding and managing the toxicities of antibody drug conjugates are critical to the continued development of new ADCs and for earlier stages and in combination. Next slide. Now, ADC induced nausea and vomiting is one side effect. Now, gastrointestinal toxicity is one of the non-hematological toxicities we see with antibody drug conjugate. The incidence of nausea, vomiting, diarrhea was higher with those novel antibody drug conjugates that reported with TDM1. Supportive therapies were not mandatory in the clinical trial with EDXT or sanistuzumab govitecan, and were left to the investigator discretions in since little advice about the management was provided in these clinical trials. Since antibody drug conjugate therapies are generally given until disease progression or toxicity, the optimal management of side effect is of key importance to improve patients' quality of life and maintain adherence to treatment and avoiding early discontinuation, which may compromise the treatment efficacy. Next slide. As I told earlier, enfortumab vedotin is a bladder cancer antibody drug conjugate for patients who are
ineligible for platinum-based therapy. We know there is about 23% nausea and vomiting with the drug. Mirvetuximab soravtaxine is a platinum-resistant ovarian cancer ADC for a folate receptor antibody. Nausea and vomiting reported is 29%. Tisotumab vedotin for metastatic cervical cancer. It is it is again IgG monoclonal antibody. Nausea reported is about 27%. Now, in all of these trials, antiemetics have not been detailedly analyzed or discussed which has to be used. Next slide. Now, if you see the nausea and vomiting incidence by the cycle in the Destiny 4 trial, which tested the drug on breast cancer, in cycle 1 and cycle 2, the incidence of nausea and vomiting were higher in cycle 1 and decreased thereafter. Next slide. The hematogenic potential of TDXT and sanituximab govitecan is increasingly recognized. However, clinical trials in Destiny lacked standardized antiemetic guidelines, leading to reactive rather than preventive treatment, despite some prophylactic use and high rates of nausea vomited persisted. That was about 73% in Destiny breast trial 04. So guidelines classification as per NCCN, TDXD and sacituximab govitecan is highly hematogenic, whereas ASCO and ESMO classifies it as moderately hematogenic at the higher end of the category. Next slide. Now, we know there is long delayed nausea and vomiting, and as well as acute nausea and vomiting. With the growing use of ADC in cancer treatment, long delayed nausea and vomiting is become increasingly relevant. Now, if you look at this slide in TDXD, it is acute vomiting. The time of onset is within 3 days, whereas in sacituzumab govitecan, it's about 8 days. Now, the median duration of nausea vomiting is 10 and 5.5 days. Median time to onset was 9.5 days and 24.5 days. Median duration was up to 3 days and 1.5 days. So, clinical implication, nausea can last for nearly half of the treatment duration, which may delay the drug administration. Late onset symptoms and shorter duration of vomiting as described. This is probably due to a long half-life and slow release of the chemotherapeutic drugs when an antibody drug conjugate bind to the target cancer cell. Next slide. This is the nausea and vomiting rates in patient receiving TDXT in the Destiny trial. If you see, the nausea and vomiting percentage is quite high across all the Destiny trial in TDXD. Next slide. What is the impact on treatment of nausea and vomiting? About 50.9% in the TDXT arm and 37 in TPC arm received antiemetic drug of the physician choice. Use of prophylaxis was not mandatory as per the study protocol, but it is recommended that antiemetics be administered in accordance with the local institutional guidelines. Next slide. Now, nausea and vomiting have an impact on the quality of the life in the Destiny, explained in the Destiny Breast 02 trial. The impact of TTXT over time on nausea vomiting was worst when compared to TPC drug. However, with TDXT, an increase in nausea vomiting scores was only significant in the early cycles. At the time of study initiation, antiemetic agents were not recommended. Protocols were later amended, including recommendations for prophylactic antiemetic treatment because of the increased nausea and vomiting noted. Patients receiving antiemetics during study treatment were 72% in the TDXT group and 31% in the TPC group, which was quite high in the TDXD arm. Next slide. What is the unmet clinical need? There is a clinical gap in guidance for management of long delayed nausea and vomiting. Identifying effective long-acting antiemetic protocols is essential, which ensures treatment adherence, minimizes toxicity, and improves the patient quality of life. Now, we know for acute nausea and vomiting, we have a neurokinin receptor antagonist, and a 5-HT3 receptor antagonist, and steroid and olanzapine. For delayed nausea and vomiting, we know a combination of olanzapine, dexamethasone, and aprepitant is used. Next slide. NEPA for patients receiving TDXT. NEPA is a combination of netopitant with palonicetron in the prevention of nausea and vomiting, which is a fixed dose combination. Next slide. If you see in the patients who received NEPA in the TDXD chemotherapy arm, during the cycle 1, nausea and vomiting was about 58% in the 5-HT3 group and 60% in the NEPA group. Vomiting was 21% in 5-HT3 group and it was almost nil in the NEPA group. Next slide. Now, in patients with cycle 2 NEPA versus 5-HT3, the incidence among 22 patients in the 5-HT3 group with nausea in cycle 1 and 15 escalated to NEPA for the cycle 2. The incidence of both nausea and vomiting decreased after NEPA was involved for antiemesis. Next slide. Now, European real-world experience with TDXD. Europa TDXD study designed to collect data from the routine clinical practice. Here they say prophylaxis for nausea and vomiting was emetic prior to TDXD. A dual or a triplet anti-emetic regimen with prophylactic intent was reported in 46.6% and 8% of the patient respectively in each of the arms. Next slide. Now, 5-HT3 and NK receptor antagonist in antibody drug conjugate associated nausea and vomiting study. This is an exploratory phase 2 study in Japan. Next slide. Data was collected across the patient groups. Now, if you see in the nausea and vomiting was much better in the triple anti-emetic prophylaxis group. Next slide. Dexamethasone sparing regimens with oral NEPA for the prevention of chemotherapy-induced nausea and vomiting were caused by high-dose cisplatin, a randomized non-inferiority study. In this study, two simplified dexamethasone sparing regimens with NEPA for the prevention of nausea and vomiting caused by cisplatin were analyzed. Next slide. Now, results: complete response rate in the patient population, non-inferiority of each DEXA sparing regimen compared with the reference treatment and was demonstrated for the primary endpoint of the overall phase. Next slide. Now, what do the guidelines recommend for nausea and vomiting for highly emetogenic non-anthracycline based regimen? A combination of 5-HT3 antagonist, dexamethasone, and NK receptor blocker plus an olanzapine combination. Similar antiemetic drugs in the highly emetogenic anthracycline-based regimen. For moderately emetogenic like carboplatin, where an AUC of more than 5 is used, and oxaliplace regimen, 5-HT3 DEXA, NK receptor antagonists. For moderately emetogenic, it is only 5-HT3 and dexamethasone combination is suggested. For low emetogenic, we could use single agent 5-HT3 antagonist or DEXA. Next slide. TDXT, nausea and vomiting, do not re-escalate TDXT dose after dose reduction. The combination of NEPA was very much helpful in the prevention of nausea and vomiting in the TDXD chemotherapy antibody drug conjugate patients. Next slide. Thank you.
Thanks, Dr. Anil. I think definitely these newer drugs, this NEPA and triple combination, definitely have revolutionized the treatment of nausea and vomiting of chemotherapy. Initially, when we started our practice, definitely most of our patients come with the anticipatory nausea, vomiting, or chronic nausea, vomiting always will be there. And we hardly see any patients complaining of nausea, vomiting with the present combination of this NEPA. So definitely, and even we were underestimating the role of this drug in especially target therapy, especially the TDXT. So definitely, most of our patients are tolerating. So I think most of our clinicians agree with this Akenzio as a go-to drug for most of the patients, especially highly embrogenic and moderately embrogenic combination. So with this, I think we will come to our the next topic of um, next topic by Dr. Ravi Chittaswamy, um, uh, sponsored by Roche. So he will be talking on we'll be talking on the role of Tecentriq in the first-line patients with advanced NSCLC not eligible for platinum-containing regime. So we have heard even in tocilizumab when in second line, third line also there is a when there is a patients are not eligible for in comorbid patients may not be able to tolerate chemotherapy. Whether immunotherapy is going to be a rule or a role model for most of the patients in second and third line. So we will hear from this Dr. Ravi Chittaswamy. Over to you, Dr. Ravi Chittaswamy.
Yeah. Uh, Thanks, Dr. Srinivas, for giving this opportunity. Good evening, all. Let me share. Can anybody share the slides, please, for me? Yeah.
Sure, sir, I'm sharing.
No, this is not. Mine is Tecentriq. Yeah.
Sir, is it visible?
Yeah, visible. Yeah. We'll start from the
Okay.
first slide. Yeah. No. I think not this one. It is atezolizumab. I will just see. I have shared here. I shared by the name of Ravi T in lung cancer. Correct. Yeah. Thank you all. So we'll discuss the role of Tecentriq in first-line patients with advanced NSCLC, not eligible for a platinum-containing regimen. And I thank Roche for giving this opportunity. Next slide. And I thank Dr. Srinivas also for giving this opportunity. So these are my disclaimers. Next slide. If we see lung cancer, it is the fourth most common cancer and one of the leading cause of cancer death. It accounts for 85% of all NSCLC accounts for 85% of all lung cancers, and majority of NSCLC are diagnosed at an advanced stage, that is stage 3 and stage 4. Next slide. So there is a large unmet need for treatment of patients with lung cancer unsuitable for platinum doublet chemotherapy. So many patients diagnosed with lung cancer are considered unsuitable for platinum doublet chemotherapy because of various reasons. So if we see in the real world and our own practice, at least 40 to 50% of the patients are not eligible for platinums, either because of the poor performance status, altered renal function, advanced age, cardiac issues, and multiple comorbidities. And many of the time they will be elderly and very frail to receive platinum doublets. So earlier we used to do only palliative care for these set of patients, but now we have got good treatment options. Next slide. So many factors we take into consideration when deciding platinum eligibility, especially the create clearance, cardiac function, the fitness of the patient, age, and majority of times, about 40% of the time, we will be unable to deliver the platinum because of one or the other reasons. Next slide. So the guidelines recommend treatment mainly based on the performance status and age. If we see majority of the trials, they were all conducted in a fit patient. Generally, in the clinical trials, age was less than 65 years, and platinum-based doublets were given only in this setting. And many of the time where they were not eligible and poor performance status, single-agent chemotherapy was tried in the form of gemcitabine, vinorelbine, or docetaxel, but their outcome was very poor. And there was a large unmet need. So this unmet need was addressed, and we will discuss how this has been addressed. So the first-line treatment for elderly patients in advanced NSCLC. So we should always look. One is the general condition, comorbidities, PD-L1 status, toxicity of the doublets, and then decide what agent should be used. So patients not eligible for doublet chemotherapy, single-agent chemotherapy was the choice, but now immunotherapy is the treatment of choice. Next slide. If we see, we all know that who are the patients unfit for cisplatin-based chemotherapy. So especially create clearance less than 50, elderly, cardiac dysfunction, these are unfit for cisplatin. And if you see who are unfit for carboplatin, especially if the performance status is very poor, and again, more than 80 years, these are unfit. So in them, we used to give single-agent chemotherapy, but now we have an option for giving immunotherapy. Next slide. So these are the overview of randomized trials which were available in this subset of patients. That is elderly, poor performance status, age above 80, gemcitabine, vinorelbine, docetaxel, pemetrexate. And if you see the results, they're all very dismal. Few PFS benefit, and there are no OS benefit. So versus best supportive care and giving single-agent chemotherapy, not much difference was there. Next slide. So evidence of single-agent immunotherapy, if you see what are all the available agents, pembrolizumab. So phase 2 study was there, but median OS was only 7.9 months. Ipinivo was tested in a phase 3 study, but it failed because of the toxicities. Durva phase 2 study also failed because of the toxicities. So elderly frail patients, all immunotherapies are not same, and there are many failed trials. Next slide. So this Ipsos study, which is a large phase 3 global study, because of this unmet need, this was conducted. In this study, Indian patients were also included. So atezo was a single-agent chemotherapy in patients who were considered unsuitable for platinum doublet was the main purpose of this study. Next slide. So coming to the results of the Ipsos study. Next slide. So if you see the background, as I discussed, why it was the study came into practice, because first-line chemotherapy, not much benefit. Doublets we cannot give. Other immunotherapy drugs like Pembro, Ipinivo, they failed. So Ipsos is a phase 3 global study, which give us at least a backbone where we can use this regardless of the PDL1. We will discuss this study. Next slide. If you see the study design, both squamous and non-squamous were included. They were all platinum ineligible. EGFR all should be negative, and asymptomatic brain mets were allowed. The subgroups were stratified based on the PDL1 and histology. So it was randomized into 2:1. One arm received atezolizumab, and the other arm received vinorelbine or gemcitabine, and they were followed. The primary endpoint was overall survival, and the secondary endpoint was objective response rate, duration of response, and PFS. Next slide. If you see the demographic characteristics, it's a well-matched study where patients were well-matched in the atezolizumab arm versus the chemotherapy arm. And especially if we see the high-risk group, brain metastasis, liver mutation, PDL1, they were all well-balanced. Next slide. Coming to the results, the primary endpoint of overall survival. So this study was a positive study which met its primary endpoint overall survival, and it is very meaningful. If you see OS of 10.3 months is highly significant in this high-risk subgroup population. Next slide. Coming to overall survival in the key subgroups, especially what I am interested is whether there is any difference between squamous and non-squamous, brain metastasis, liver metastasis, number of metastases, and PDL1. So this was a positive study across all the subgroups, and all the subgroups derived benefit. Next slide. Coming to the secondary endpoint of PFS, if we see the PFS was 4.2 months in the atezo arm versus chemo 4 months. Again, it is significant, but generally we know that immunotherapy PFS is not the only criteria. OS is the criteria. Next slide. So objective response rates, we generally think immunotherapy, the objective response rates are less, but it is not the case. We can clearly see here atezolizumab patients had good objective response rates. Next slide. So coming to the quality of life, so if you see the quality of life in the immunotherapy arm versus the chemotherapy arm, it was well maintained in the immunotherapy arm as compared to the chemotherapy arm. Next slide. Again, it suggests that the various parameters we studied the quality of life, it was highly improved in the patients who are on immunotherapy arm, that is atezo as compared to the placebo arm. Next slide. Coming to other symptoms like pain, fatigue, dyspnea, all these things were reduced. Those who are on immunotherapy arm. Next slide. So if you see the adverse events in the atezolizumab arm, apart from standard immune-related side effects, that too, they are all significantly less in this study, especially the grade 3-4 toxicities. What we come across, they are all very less in this atezolizumab as compared to other drugs like Pembro, Ipi-Nivo combinations. And even with compared to chemotherapy, it's a well-tolerated regimen. Next slide. Next slide. So coming to some of the important adverse events, and generally what we have faced in our practice is hypothyroidism and skin dryness, and some small percentage of diabetes. But if you see this hepatitis, immune-related carditis, they're all very negligible in our own practice, and also in this IPSO study also, they were all very negligible, especially the grade 3-4 toxicities. Next slide. So the IPSO study empowers us to majority of our patients, what we practice, especially PS2 patients, elderly patients, not fit for tablet chemotherapy because of the age, comorbidities. This is the regimen of choice to go. Next slide. So even the guidance recommendation, it says that because of this landmark positive study, atezolizumab should be the treatment of choice in elderly patients, frail patients who are not fit for chemotherapy doublets, and all the guidelines, ESMO guidelines, ASCO guidelines, they all given as a category one recommendation for this atezo regimen single agent in this subset of patients. Next slide. So to conclude, first-line atezo significantly improves OS over the other chemotherapy agents. The OS benefit is very robust. The objective response rate is very robust. So the quality of life is improved in those patients who are on atezo arm. The toxicities are very less, especially grade 3 and 4 toxicities. And Ipsos is the first randomized phase 3 study to show that first line therapy in this subset of patients, elderly, frail, irrespective of PDL1, those who are EGFR and ALK negative, atezo should be the treatment of choice. Next slide. So with this, I will conclude, and I thank Roche and Dr. Srinivas for giving this opportunity. Thank you.
Thanks, Dr. Ravi. So definitely, most of our patients with NSCLC will have comorbidities, and most of the patients may not come to second line itself. So in those cases, I think definitely this is the treatment of choice. Have you any experience with this, sir? Dr. Ravi, sir?
Yes, yes, yeah.
Second line, have you?
We have used and as it is rightly mentioned, the quality of life tolerance of this drug is
Irrespective
very
of
good.
PDL1 status, we can use.
Yes, yes, yeah. Irrespective of PDL1 status and irrespective of whether squamous or non-squamous, we can use this.
Okay, okay. Yeah. Yeah, so definitely, I think immunotherapy is, as we have told initially in our presentation, immunotherapy is revolutionizing the treatment across all the solid tumors. So that is why this webinar, and we learned about the immunotherapy resistance also, and what next after immunotherapy, because so many immunotherapies are coming. So next, we will thanks Dr. Ravi and thanks Dr. Roche for giving this opportunity. And I will invite our one more young oncologist, Dr. Vijay, who passed out from HCG only, now in Rajasthan. He will be talking about the immunotherapy related toxicities. So because so many immunotherapies are using, so even the rarer side effects like myocarditis, some other cancer, other pituitary related events are becoming more and more we are seeing clinically. So to put light on that, I think most probably our Dr. Vijay is going to throw some enlightening on some of the toxicities, highlighting some of the toxicities.
Thank you, sir. Can I share my slide? Is my slide visible?
No, sir.
Now?
Still not.
Yeah, no. Now?
Now it's visible, sir.
Yeah. Good evening, everyone. I thank the organizers and Srinivas sir for giving this opportunity to present on management of immunotherapy related side effects. So, immune related side effects, it's a spectrum of disorder which can affect any organ of the body from head to toe. And most commonly affected is skin and GI. But it can name any organ, it can involve any organs. And so we have to have a high level of suspicions to diagnose this. As a result, we can initiate the early treatment, and some immune related adverse events are life threatening. So, which has to be addressed as early as possible. So the most common immune-related side effects are dermatological and diarrhea. Apart from that, we can also have hepatic, pancreatic, and endocrine. Among the dermatological, the most common presentation is maculopapular rash. They can also present as blistering skin reaction in the form of bullous lesions, or they can have psoriasiform lesions, or sometimes chronic lesions such as lichenoid lesions also can be there. And among the GI toxicity, the most common is a diarrhea. Apart from that, they can also have the colitis like features like fever, hematochezia, and blood in the stools. And hepatic toxicities are usually asymptomatic. They can also present with high enzymes and high bilirubin levels. And other most common toxicities is endocrine toxicities. Thyroid dysfunction is the most common. Apart from that, the patients can also have hypophysitis or steroid imbalance as well. Other less common side effects are pneumonitis. As I mentioned before, it is one of the life-threatening event, and other life-threatening immune-related adverse events are myocarditis and the neurological side effects such as encephalitis and myasthenia crisis. They can present with. Apart from that, patient can also have a renal dysfunction in the form of raised creatine, or they can have proteinuria, and ocular adverse events such as scleritis, uveitis, and retinitis also can be presented. Apart from that, patient also can have arthritis, arthralgia, myalgia, and myositis can be presenting features. So these are the common histopathological features whenever we suspect grade 3 or grade 4 immune-related events. When we do biopsy, the most common finding which we see is lymphocyte-rich infiltrates. Apart from that, we can also see mixed infiltrates or antibody-mediated and antibody-mediated reaction as well as complement-mediated reaction can also be seen in the histopathology. So these are the common sites of, for example, when we use CTLA inhibitors, the most common adverse events are skin and GI, and the adverse events are more in CTLA compared to PDL1 and PD1 inhibitors. The adverse events are very less for PDL1 inhibitors such as atezolizumab and durvalumab, whereas it is more for CTLA4 inhibitors. And coming to grade 3 and grade 5 toxicity, again, among the CTLA4 inhibitors, GI toxicity is more common in among the CTLA4 inhibitors. So these are the general guidelines in management of immune related adverse events. So we have most important thing is whenever we encounter immune related toxicity, we have to grade them into different grades, and these grades are different among different organs. In common, the grade 1 is basically asymptomatic or mild symptoms, grade 2 are moderate symptoms, and grade 3 usually requires hospitalization, whereas grade 4 is the life threatening event. So, what are the strategies to prevent and monitor immune related adverse events? First thing is we have to do the baseline assessment whether the patient has any ongoing complication even before starting immunotherapy, such as the patient has any rheumatological disorder, or the patient has any endocrinological disorder even before starting, we have to assess. And this has to be kept as a baseline record to compare. And second thing is when we encounter adverse events, we have to risk stratify into various grades, and we have and treatment also depends on the comorbidities of the patient as well. And we have whenever we suspect immune related adverse events, early intervention is a key, and once we lose the time point, sometimes we might lose a patient as well. And most of the time, it is always a multidisciplinary collaboration. For example, if the patient with rheumatological disorders, we need to get the opinion from the rheumatologist, and patient with hepatotoxicity we have to get the opinion from gastroenterologist, and it's such as whichever the organ is involved, we have to get opinion from such a specialist and treat accordingly. So this is again the general rule in managing immune-related adverse events. Grade 1 usually does not require any specific treatment, whereas grade 2 we normally used to stop the immune-related immunotherapy and wait for it to come to grade 1 or normal, then we can restart. Whereas in grade 3 and grade 4, we have to stop the immunotherapy and we have to start on IV steroids, usually the dose of 1 to 2 mg per kg. And whenever the grade 3, again, restarting at grade 3 depends on assessing the risk and benefit. If at all the adverse events comes to grade 1 and if there is a significant benefit in continuing immunotherapy, in such case we usually re-challenge with immunotherapy. In grade 4 in generally we do not re-challenge with immunotherapy. So this is what I told. Grade 1, we can continue the immunotherapy with close monitoring. There are some exceptions whenever when we consider neurological or cardiac. In such situation, even grade 1, we have to stop immune checkpoint inhibitors. And grade 2 toxicity, we have to hold the immune checkpoint inhibitors and start on corticosteroid at lower dose at 0.5 to 1 mg. And and in this exceptions are pneumonitis. Pneumonitis has to be managed aggressively, and because they progresses very fast. And grade 3, we have to hold immune checkpoint inhibitors and start steroid at 1 to 2 mg per kg. And sometimes we have to start pulse steroid in case of neurological disorders or myocarditis in that case. And grade 4, usually permanently we have to discontinue immune checkpoint inhibitors. Exceptions, again, in this case are endocrinopathies. In endocrinopathies, we can always restart the immune checkpoint inhibitors with adequate supplementation of the deficit hormone. So this is a time point when the immune-related adverse events are commonly happens. The most earliest manifestation will be the skin reaction, which usually happens between 3 to 8 weeks. The second early event will be for the diarrhea, and usually hepatotoxicity or other complication happens after sixth week. That is after the second cycle of immunotherapy. These adverse events are more common. And whenever we manage immunotherapy, there is always the fear of stopping immunotherapy. What if the disease progresses, or what is the outcome when we stop immunotherapy? As seen from the previous presentation, also, it is very safe to stop immunotherapy. There is no much difference between PFS and OS, even when we discontinue immunotherapy due to immune-related adverse events. In fact, it is better when we do it. The OS is slightly better in patients among who developed immune-related adverse events. So, and the immunotherapy-related adverse events can even happen 2 to 3 years after stopping the therapy. There are some retrospective data which showed 13% of immune-related adverse events happens more than 4 months of stopping the treatment. So we will now focus on system-wise. As I told, the most common is the dermatological reactions. So they are basically graded based on the involvement of body surface area. Less than 10% is grade 1, 10 to 30% is grade 2, and more than 30% is grade 3. So as I told earlier, grade 1 does not require any stoppage of immunotherapy or any treatment, whereas grade 2 we temporarily stop and start on topical steroids. For grade 3, we can start on systemic steroid with the form in the dose of 0.5 to 1 mg per kg. And usually for maculopapular rash, there is no grade 4. Whereas for other skin reactions such as bullous dermatitis, there is always stage 4, which is life-threatening event, which is defined as more than 30% of body surface area with fluid or electrolyte imbalance, or patient has hypotension. They are categorized into grade 4. In these patients, again, we don't re-challenge immune checkpoint inhibitors, and we start treatment with 1 to 2 mg per kg of dose. Whenever we start steroids, we have to closely monitor. If there is no response between 48 to 72 hours, we have to add the second line agent. So in skin reactions, we can always add MMF and other agents such as infliximab in life-threatening conditions if there is no improvement with steroids. So these are the endocrinological disorders. As thyroid dysfunction is the most common endocrinological disorders we see in immune 1 inhibitors. First, we have to do the baseline evaluation before start the immunotherapy to see whether there's an underlying hypothyroidism is there or not. So usually the immune checkpoint inhibitors related thyroid dysfunction, it start as a hyperthyroidism, then it goes into thyroid deficit state. So whenever we encounter hyperthyroidism, we should not jump and start anti-hypothyroid medications, because most of the patients will eventually land up in hypothyroidism. So whenever there is a low TSH and low TFT4, we also have to check the 8 am cortisol levels. And if the 8 am cortisol level is also low, we have to assess the HPA axis to add whether patient requires a further steroid or not. So when we patient has hypothyroidism, we can start thyroid dose at 0.5 to 1.5 microgram per kg, and we can titrate the dose according to the response. And thyrotoxicosis, whenever we suspect severe hypothyrotoxicosis, then only we have to consider adding the agents like carbimazole for Graves' disease and propranolol for symptomatic management. We can do it. For painful thyroiditis, we can consider adding steroids at the dose of 0.5 mg per kg. So this is again a pituitary axis assessment. Whenever we suspect hypophysitis, again we have to grade them into grade 1, 2, 3, and 4. Usually we don't start with 1 to 2 mg per kg except in grade 3 and grade 4. Grade 3 and grade 4 is defined as a severe mass effects in the form of headache. Patient might have headache and visual disturbance. In such patients, it is better to start with IV methylprednisolone of 1 to 2 mg per kg and assess according to their response. So rest of the patients, we can start with 0.5 mg per kg and maintain the cortisol levels in these patients. So this is somewhat similar to how we treat Addison's disease in general.
So sorry
Coming
for the
to
interruption. Kindly conclude.
so other common toxicities like gastrointestinal toxicities, diarrhea and colitis, which is also more common. The treatment strategies is similar. Only one exception which I wanted to tell is in hepatic toxicity. Whenever the second line agents, we commonly use infliximab as a second line agent, whereas in hepatic toxicity, infliximab is contraindicated. In such case, we have to use MMF as a second agent. So other less common adverse events are immune-related myositis, pneumonitis in lung, and immune-related myocarditis and immune-related nephritis and renal toxicities. Among other adverse events, fatigue is the most common immune-related adverse events. Whenever we encounter fatigue, we have to rule hypocortisolism in this patient and hypothyroidism in this patient before we conclude it is immunotherapy-related fatigue. So this is a slide like when to re-challenge and when not to re-challenge, which we have already discussed before. There's one point which I want to tell. Whenever we encounter grade 3 CTLA related colitis, we normally don't re-challenge with CTLA4 inhibitors. So these are the our experience in managing immunotherapy related. We had encountered patient with grade 4 hepatitis and patient with squamous cell lung carcinoma who has been treated successfully with 1 mg per kg of steroids. And there are a few of my colleagues also have encountered myocarditis. Those patients also has been successfully treated with steroids. And something which is unusual is in whenever we treat Hodgkin's patients as a salvage or in hematological malignancy, we don't see much immune-related effects. And some peculiar side effects, like in post-transplant, we see exaggerated CRS in patients who received immunotherapy as a salvage regime in Hodgkin's lymphoma. So these are my concluding points. And I once again thank
Thank you.
organizers and Srinivas sir for
Yeah.
this opportunity. Yeah.
Thanks, Dr. Vijay. So you always response whenever I invite you for the talk. I definitely thank very much.
Thank you, sir. Thank you.
So definitely the immunotherapy benefits are definitely the thing of we should know more about these opportunities because most of the patients, because more and more immunotherapy we are using, more and more toxicities we are encountering, especially the rarer side effects like myocarditis we have encountered, hepatitis we have encountered, and pituitary hypophysitis we have encountered. So definitely we should know most of our clinicians know about this. I think we should update regularly on a day-to-day basis. So I thank all the speakers, including Dr. Vijay from Rajasthan, Dr. Vivek, Dr. Satish, Dr. Ravi Swami, Dr. Anil Kumar, and all other consultants. And thanks sponsor Glenmark, Roche, and DMS for sponsoring the session. And most not the least, the Horizon, which has provided a platform and coordinated in the background for all the slides and technical things. So I thank everyone, and we have learned a lot about the immunotherapy, and more webinars we are going to conduct in future. Thanks one and all, and with this we will conclude the session. Thank you everyone who participated in this session.
Thank you, sir. Thank you so much. Thank you, everyone, for joining. Good night, everyone, till we meet again. Thank you, Daud. Thank you,
Thank you,
Yash.
ma'am.